Hello, everybody. This is episode 90. It's the last episode of season 3. My name's Andrew Gums. I'm very happy to have Dr. and Professor Nicole Bouvy. Am I saying it properly? It just occurred to me I was about to say Bouvet, but it's not Bouvet, it's Bouvy.
You live in France now, eh? You know how to pronounce it.
Oh, this is interesting because you're located not in France, if I remember
No,
correctly. Oh,
in the Netherlands.
this is gonna
Yeah.
be an interesting conversation. So, we are artificial intelligence and cybersurgery. This is the official podcast of our journal, Artificial Intelligence Surgery, the first journal dedicated to artificial intelligence and surgery. And I will let my partner and co-host, Dr. and Professor Vincent Grasso, introduce. I think I already did, but I'll let you reintroduce our next guest. Sorry, I stole your thunder, Vincent.
No, it's quite all right. I'm used to that by now. It's a great pleasure to have you, Professor, on. And for our audience, they're excited to learn more about what you're doing. You're obviously a professor of surgery. You're in the Netherlands and the president of the EAES, which is quite an honor. So please, let our audience know about you, your background, as Andrew mentioned, and we're happy to have you on the podcast. Thank you.
So thank you for having me in your podcast, and really loved past season. So that's great. So I was trained in the Netherlands, in Rotterdam. I worked in Maastricht for 21 years as a surgeon, and recently, 1 year ago, I moved to Leiden to be the chair of the Department of Surgery over there. And Leiden is the eldest university of the Netherlands, very into image-guided surgery, data-driven AI.
We'll get to that, but I must know, are you born in the Netherlands? Because Nicole Bouvy sounds like a French name, so I'm a bit confused now. What's going on with that?
So I was indeed born in the Netherlands, but 5 generations ago, my family came from France. Yeah.
Ah, okay.
And Spain and Norway, they're all over the place.
Okay,
Yeah.
where in France is your family from? What part?
The south of France. There's even a town called Bouvy over there.
Oh, interesting. Is there anybody in your family that's a physician, or are you the first one in your family?
No, actually both my parents were physicians. So my father also was a surgeon and my mother a psychiatrist. Yeah.
Yeah, my father was a surgeon also, so I can relate. Vincent, I think, are you the first doctor in your family?
Yeah, in my immediate family, yeah. My father was PhD chemist, but I'm the first surgeon in the family.
Nice. And so you are mainly interested in the upper GI tract, if
No, since I did my PhD in 1993 in Rotterdam, and we wanted to start a trial on laparoscopic colon surgery in the Netherlands, but this was not approved by the Medical Ethical Committee due to abdominal wall metastasis.
Yes.
So
you were too far ahead of the curve.
Yeah, and that's why I was already starting my PhD, and so we transferred this PhD to an animal model in which we inoculated tumor cells in a rat model, so small animal, and did laparoscopic surgery in that animal. And we did all kinds of experiments and find out that these end metastases were not due to probably CO2 pneumoperitoneum or the migration of tumor cells through trocar wounds, but by direct tumor wound contact. So at that time, we wanted to extract the colon carcinoma via an incision that was really small, and we did not put the tumor in a bag before extraction, or did not protect the extraction site. It was an interesting time because we also did all kind of other experiments, and we even had a World Red Forum of surgeons performing laparoscopy in this model.
Wow.
Mark Bessler from New York and
I trained
Berlin.
with Mark Bessler. I was his minimally invasive fellow at Columbia. And
Okay.
And it's funny that you say that, because I was actually remembering, like, Vincent, you remember the days when laparoscopy and cancer surgery were a big no-no. It's it must be hard for the young generation to even believe that, but it was a complete no-go zone. It's
Indeed.
interesting to know the hurdles you had to go through. You had to create an animal model to prove it. My God.
Yeah.
Incredible.
Yeah, interesting times indeed. Well, and then at that time, of course, I was also already involved with SAGES and the EAS, and presented this work, and did more and more at the European Association of Endoscopic Surgery, the technology committee, making the program for many years, including the Corona years. And then in the end, since last year, I became the president of the EAS.
Yeah, that's quite the honor. I think what's the next step? I guess Nobel Prize. That's it. I don't know. After that,
Becoming a grandmother.
Okay. Even greater, of course,
Yeah.
of course. I was actually I know that surgical endoscopy, SAGES and EAES are creating another journal. It's interesting. We're obviously involved with Artificial Intelligence Surgery Journal, but it's interesting to me how many societies don't own their own journals, and it's a very interesting time as far as that's concerned also. So SAGES and EAES are starting a new journal based a little bit more, not just on endoscopy and laparoscopy, but also on newer technologies and of course, artificial intelligence. But it's a real
So innovative surgical trends, and we try to focus, because surgical endoscopy does not accept papers with less than 8 persons, or animal work, or that kind of topics, or new techniques that really are in the pilot phase. So innovative surgical trends focus on this, but also on items like you say, AI, sustainable surgery, and also what we have in mind to be a platform for databases, so that we can really make huge databases, data science, and in the end AI out of these data, with all these journals, with all these data.
Yeah, no, absolutely. We're involved with a project trying to collect data specifically for pancreatic cancer, and collecting data, but on top of it, collecting visual data from CT scans, collecting pathology data. It's a problem because it's expensive to house all of that in the cloud. But absolutely, big societies like EAES and SAGES are perfectly poised for that, because ultimately, maybe I was in America too long, but ultimately that can translate into money that can help fund further research and help us analyze a lot of that data and create algorithms so that we can make better decisions on our patients. So has SAGES and EAES, are they also thinking about having suppositories for visual data so that they can maybe start to create some of these algorithms?
Yeah, in a way we are working together on that, and what you say is true, because there we have a bit of a different vision probably in Europe versus the US. So we really want to use AI to democratize expertise, to make surgery safer, with less variation, scalable mentorships, and global quality improvement. And we want to provide our members this for free. So together we work on standardizing the steps in, for example, laparoscopic cholecystectomy, fundoplication, colon surgery. Then we want to use this as a tool to upload your video. If you work in Africa, Australia, Europe, and to get directions to improve your surgical skills.
That is fantastic. I've since moving to Europe, I've really seen a different spirit, with all the things that you just said. And one of the reasons I wanted to move back to Europe is, I did some fellowships. I did fellowships in Italy and in France, and I always felt, just like you said, the mentality, the spirit of surgeons is different, shall we say, in Europe, and it's a beautiful thing. You have obtained something that in America, most countries around the world would be very difficult. To be a woman who is a chairman of a department, who is president of a massive society. Can you give us a little insight of what that was like? I mean, obviously, you're in a very open-minded country, but nonetheless, you must have had some interesting barriers to overcome. Can you give our listeners a little bit of insight of what it was like back in the day and how things have changed and hopefully gotten better? And the reason I'm asking is we're also our official partner is Women in Surgery Italia. So, we try to get more women involved in the STEMs, the science, technology, engineering, and mathematics. So another reason why we love to have you as our 90th episode.
Yeah. So, I was lucky to be born in the Netherlands because gender equality is quite common here in the Netherlands. I was lucky to be born as a daughter of a surgeon, and I was lucky to have 3 brothers. So
Tall.
I exactly
Tall brother.
well with the four of us, we were in 4 years. So my mother did a great job.
Wow.
And respect for her. So I was second in line, but we were more or less the same age, and that really helps, of course, to understand male better. So I exactly know how to deal with male, and I never find the difference between female or male in getting along with either of those sexes. So that helps. And I was lucky to when I started my surgical residency, it was already a bit common. Well, not so common, of course, but there were female residents before me. So that helped. And they paved the way. And also, I think I was lucky having healthy children and having nannies that were really great. So I did not have to worry about what happened at my home. I was happy and lucky with my husband. I think it's important to have a husband who also loves to run the family and can be there if you are on duty, and so that helped. What else?
Do you read?
I was lucky to have a mentor who really believed in me, and also helped me to get certain jobs. That kind of things are all important. Yeah.
Because you mentioned something how, the idea is people can send their videos and they can get evaluations and help and assistance. A lot of that can be done with AI now, and it can be done autonomously. And I wonder, in the past, at least in other countries, a lot of women and minorities maybe were judged differently when they had complications. But one of the beautiful things about now is a lot of the surgery is done minimally invasively. A lot of the surgery is recorded, and a lot of things can be kind of analyzed anonymously. Do you think AI and kind of a automatic assessment of surgical video can help these type of things going forward in the future?
Yeah, that's how we should use AI, I think, to really to scale up mentorship and to get global improved quality, and that all surgical procedures really are done in the same quality. Yeah.
Yeah. So, we just had a podcast when, someone was mentioning that it's hard for people to have the time, active surgeons to have the time to learn about AI. It's hard for them to find time to do a master's. Heaven forbid, you can't do a PhD once you've already done a PhD. You just don't have the time. How does EAES plan on helping form the next generation of surgeons to learn more concepts of AI? Are there going to be are you guys thinking about doing courses or funding fellowships? Like what you've obviously EAES and Sage has done an amazing job of training people with FLS and things like that. But AI is a little bit of a new beast. What are kind of the things that you think would be a good idea for a society like EAES to do?
So, well, great that you mentioned this. So, the EAS already has master classes on AI for I think already now the fifth year, and they're really attended very well. We developed EAS curriculum on topics like laparoscopic colon surgery, hernia surgery, but the next will also be AI in surgery. So that's important. And we are also planning to offer fellowships in clinics that have already many AI tools incorporated in their surgical clinics. And the other thing is that you do not have to know how a computer works to use it, and so we try to share confidence using AI for many surgeons without exactly knowing how it works or so, and that's also important. Yeah. And of course, you have to be aware of ethical things if you're going to use AI, but that will be incorporated in these curricula.
So, one of the things I've been arguing for is that much like in radiation oncology, where they have a full-time physicist on staff, surgery departments, our bottleneck is collecting data, collecting good data. I think, there's a huge problem with money, so we're not going to talk about that. But in an ideal world, every surgery department would have someone who would be able to collect data and maybe someone to analyze that data. Is there going to be a role for this in the future in departments, in maybe with SAGES? It's Vincent, remind me, it's called the Chief Information Officer.
Yeah, Chief Medical Information Officer.
Yeah. It's
Yeah.
I don't know how to solve that. Like I like the idea of taking a young surgeon, maybe having them do a master's, maybe having them do a PhD, But I wonder if we're going to, every hospital, or at least every hospital, but maybe every department is going to need someone dedicated to analyze the enormous amount of data that's created in the operating room and outside the operating room every day, every day. What are your thoughts on that?
I think what's very important, if you put garbage in, you get garbage out. So what we did together with SAGES and George Hanna, chair of the Department of Surgery at Imperial College, former president of the EIS, he created all kinds of tools so that all the steps within surgery are analyzed in a very standardized way. And if you identify the different steps of surgery, you can also analyze these steps by AI. So you do not need endless fellows or surgical residents.
You can use AI to do a lot of the crunching.
You can use AI to do that. So I'm convinced that this very critical and structural way to analyze videos will help to really analyze these video data. And if we combine them with preoperative data and with postoperative outcome, we create a kind of surgeomics, like proteomics, a footprint. And in the end, this footprint and data can give real-time feedback during surgery to say, okay, go a bit left in this patient or a bit right, or in this patient with this preoperative data, with this perioperative anesthesiology data, go for stoma and not an anastomosis in colon surgery, or go for a bit larger mesh in hernia surgery or a bigger overlap. And this can really help making our outcome for surgical procedures better, I think.
Absolutely, absolutely. You know, one of the things that kind of Vincent and I struggle with is, 60% of the world has no access to a doctor, and 60% of the world has no access to a surgeon, and sorry about that. It's my birthday today, so I'm getting a lot of phone calls.
Congratulations!
Yeah, thank you. So, our concern is the robotic revolution is taking up a lot of dollars. Europe is a lot better at spending their healthcare dollars. I worry that by spending all of this money on these big expensive robots that we're not having enough money for AI research. Now, obviously, EAES does this a lot better, but what are your thoughts on where robotics is headed? Are you thinking AI is going to become more and more important, or should we get more and more robots so everybody knows how to do a robot? Should we get smaller robots? What is the EAES thinking about robots? I feel like we can't even have this conversation because some of the players have become so important, but hopefully I don't put you on the spot with this question.
Yeah, no, not at all. So at the moment, 75% of the world population has access to the internet. Yeah. And only a small portion of the patients or future patients will have access to robotic systems. So I think if we want to have equal access to surgical procedures worldwide, we should focus on laparoscopic procedures rather than robotic procedures. Yeah. And then we have the environment. So robotic procedures, they have 10 times more greenhouse gas emissions compared to laparoscopic surgery. Right. If we first think of the best outcome for the patients, we cannot limit ourselves to the operating room. We also, of course, have to think of other things. We cannot destroy the environment in which our future patients live, and then at the same time creating disease by destroying our environment. So in the end, if you think of our world, energy will be not a problem, but ground substances will. So if we want to go on with robotic systems, in my opinion, we should work on more and more sustainable robotic systems, because otherwise, at the moment, there are almost no benefits for the patients to be treated by a robotic system. And it's a lack of skills of surgeons to not perform this in a laparoscopic way, if it is so. So we better focus on improving the skills, the laparoscopic skills of surgeons, than go for robotic systems. And I had discussions with the board of sages that it's really becoming a serious problem now that in the US surgeons are trained with robots to do laparoscopic cholecystectomy or inguinal hernia repair, then go to another hospital if they are a surgeon that do not have robotic systems, and they are not skilled to perform surgical procedures. So we really have to stop this. And for example, robotic systems say that the learning curve is 50 for performing laparoscopic cholecystectomy. So in your surgical residency, you probably do not many more procedures than 50. So there's no space for laparoscopic cholecystectomy anymore. And well, I was the first one to do robotic surgery in the Netherlands. Oh, wow. And I did not need more than 5 procedures or 2 procedures to go to my learning curve for laparoscopic cholecystectomy. So it doesn't make sense at all to ask 50 procedures for your surgical residency program, in my opinion.
Yeah, no, you open your mouth and I agree with everything, which is fantastic. You don't know this, but after we met at the last EAES meeting in Porto, I was so impressed with you that I ended up joining EAES because I realized I have found my people. I am so aligned with the mission of EAES, so I really look forward to seeing you again in Athens in a few weeks. And I couldn't be happier to be a member. Vincent, I'll let you say a few words because I know I kind of monopolize things, and then Professor Bouvy, I'll let you say some final words because unfortunately our time is coming to a close. Vincent, what do you think about all these wonderful things about that we're hearing about the EAES?
It's an amazing amount of work Nicole's doing, and the society is outstanding. I just still have just at a quick level, at least in the U.S., the revenue generating engine of a hospital system is the surgery department, right? The interventional component of the machine, so to speak. And I've always been a proponent that surgical departments need to hire 3 people: an MBA that has solid financial understandings, a software architect to be the brain of how software and AI can actually be implemented. And as you mentioned, the data visualization person, the person that can look at data and visualize it and make sense. Those 3 people, I would be surprised if any department of surgery has hired them yet. They view them as, oh, they're an expense, it's expensive. But meanwhile, hundreds of millions of dollars are being generated by those departments. There's a lot of money that runs through them, but they still haven't allocated that as something that the 3 of us would think would be very important, and we would make use of. So that's a challenge. On the surgery side, in the global space, If your general surgeons don't have good hands and they can't do surgery without a robot or a scope, that to me is a mismatch. That foundation, I think, is essential. And do we send our first year surgical residents or second offshore? Do they go to India, where there's massive volumes of surgery being done, that they can learn how to do things and then come back? I mean, in a surgical residency program in New York, how many gastrectomies get done? How many bleeding ulcer? How much GI foregut surgery is being done by a general surgeon? And I don't know. It's an interesting series of obstacles. But between the two of you, you have your pulse on what's happening and can influence the next generation of training. So that's why it's so exciting to see how we can help move these along.
Yeah, that's why we are very proud at EAS to have so many educational programs. And it's really our mission to connect to the rest of the world and take care of each other, but because that's also a very important theme, the work-life balance, so that future generations would still love to become a surgeon, but also take care of our planet, not to destroy the back garden of our future patients, to create more patients.
And to leave a beautiful world for grandchildren. I love that.
Yeah, because that's my mission, to become a grandmother.
Yes. Thank you so much. It was a true pleasure, and we'll see you shortly in Athens.
Yeah, and Andrew, we are honored that you're a member of our society.
Thank you.
Okay, see you.
Bye-bye.
And happy birthday, Andrew. Happy birthday. Many more.
Yeah. Congratulations.